And it is my pleasure now to introduce our keynote speaker, Barb Farrell, who's going to be talking about creating and implementing deprescribing guidelines. What research do we need to make a difference in the real world? And just by means of introducing Barb, when Cynthia and I when the idea of creating this US-based deprescribing research network really first germinated, we really looked to the people who have been the leaders in this field up until that time and continuing through this day. And those leaders basically came from Canada and Australia. And in thinking about who were the real leaders, Barb was clearly kind of at the very top echelon. So Barb she has a million titles, so I'm going to read them here because I can't remember them all. She's officially assistant professor in family medicine at the University of Ottawa. She's adjunct assistant professor in the School of Pharmacy at University of Waterloo, and a bunch of other titles as well. But most importantly, for our context, Barb is really the driving force behind Deprescribing.org, which many of you are kind of familiar with, which is that go-to site that has evidence-based deprescribing guidelines for how we can take this kind of morass of evidence and really put it into very clear operational terms about how to actually improve the care of the patients who we serve. And Barb has been instrumental not only in kind of disseminating that materials through Deprescribing.org, but leading the evidence generation and leading the guideline development process, and just being a huge advocate and guiding force for deprescribing and deprescribing research ever since this field sort of took off, 10 or so years ago, a large part due to her leadership. So we're so delighted that Barb's joining us from way up north in Ottawa. And thank you, Barb.
Well, thank you, Mike, for a wonderful introduction. And I'm so excited to be here, to actually see a group of people. This is so, I'm just so excited to see you and to be here where it's warm in Florida. Cheryl was telling me they de-iced her plane on the way here from Edmonton yesterday. So it's still a little cold at home. So I'm delighted today to share with you our experience in developing deprescribing guidelines and some of our implementation experience as well. But what I want to do is start really with my experience working in a geriatric day hospital. So I've been working as a pharmacist in this geriatric day hospital team, an interprofessional team, outpatient clinic where we see older people who have cognitive impairment, falls, declining function, difficulty managing things at home, and I do the medication review and the polypharmacy assessment and guide the deprescribing. And I've been in this practice since 1999, so a lot of the work that I'm doing now in deprescribing guideline and other deprescribing types of studies really emerges from that experience working in the day hospital. And so I thought I would start with a real patient that I saw in the fall. This was a 76-year-old woman who came to us with cognitive impairment and falls. And in talking to her, it was very interesting because she had a lot of word-finding difficulties. She wasn't able to finish a sentence in a conversation, could not finish any sentences. Family was worried about her management of appointments and finances. She was not taking medications routinely, very erratic. Taking the doxepin every day, though, and as you can see, she was taking 250 milligrams a day, which she had been taking for about 30 years. So it's not hard to identify that that's a problematic medication in terms of cognitive impairment, but everybody up until this time, including the memory disorder clinic where she had been assessed and diagnosed with Alzheimer's, had not addressed reducing the doxepin. And I just feel, I see it over and over, people seem paralyzed. They're able to identify the medication's problematic, but they don't do anything about it. And I think in this case, we don't know very much about what to expect in terms of adverse drug withdrawal events from tricyclic antidepressants. We have a sense of what they might be, but we don't know how severe they'll be, when they'll appear, what's the frequency, what's the timing, how long do they take to resolve. We don't know any of that information. So people ask these questions. Well, what will happen if I stop the drug? Will her mood get worse? Will she have withdrawal? How severe will it be? How do I handle that? How fast do I taper? By what amount? By the time they've asked all these questions, they don't have time to really deal with it. So I thought I'll come back to this case at the end and talk a little bit about it, but it gives you a sense of the type of thing that I run into in practice, which I'm sure many of you do as well. So in terms of my process, typically when I look at a patient, I'm thinking about can whatever problem they have be caused by a drug. I look at each drug and I assess the indication, the effectiveness, the safety, the compliance with the medication. It's pretty easy to check drug interactions now to calculate anticholinergic burden, to look for potentially inappropriate medications. I look at all of that, I identify drug-related problems, develop a care plan. I develop a plan for implementing that, and a lot of my patients are taking 20, 25, 30 medications, so the plans can be quite intense. And then over a period of 8 weeks, which is our admission, and people are coming, they're outpatients, so they're coming a couple times a week, we carry out and monitor that plan. So just a show of hands, is there anybody who thinks that that might be a challenging process? Pretty much everybody, yes. Challenging and time-consuming. So in my practice, I've mentioned this already, there's a lot of facilitators. We have screening criteria for potentially inappropriate medications. We can calculate anticholinergic burden. We can use drug interaction checkers online. This checking for indication effectiveness, safety, compliance is very much incorporated into the pharmacy curricula, so it's sort of second nature. We know a lot about how medications cause side effects, and in particular for me, because I've been in this team for so long, there is very high trust. But it's still challenging, as you've all identified. It's time-consuming. We're often missing information. We don't know why patients were started on medications. We don't have a lot of evidence to go on in terms of how medications are effective or not effective as they get older. It's difficult to make decisions when risks and benefits are uncertain. It's hard to get agreement from all of the different carers, prescribers, family members. And we're uncertain about what is the safest way to deprescribe. And I find all of that is paralyzing, as I said. And there is a potential, I think, when you make a change like that, to lose trust with either the patient or the other prescribers. So Mike talked a little bit about my background in the deprescribing research. I actually started doing this kind of work in the early 2000s. I began this position at Bruyère Continuing Care in 1999, and in the early 2000s we did some targeted medication withdrawal studies in our inpatient side, where we reduced and stopped medications like cisapride, baclofen, dantrolene, and we were able to demonstrate really about half the patients didn't seem to need the medication. Several patients got significantly better after stopping the medications, and some patients needed small doses of the medications. So it was sort of a proof of concept that, yes, we could reduce and stop medications. We also did some observational work with benzodiazepine tapering in the day hospital because we were finding we were quite successful with it, so we published about that. And then, because I was working very closely with the family physicians on our team, we talked a lot about, wouldn't it be great if pharmacists and physicians could work more closely together? So we actually got funding from the federal government to study the integration of pharmacists into family health teams, the provincial government for that particular grant. So we studied this practice of pharmacists working with family physicians, and Elisa McCarthy, who's here today, was one of the pharmacists actually hired in that particular study. And that's been ultimately very effective. We started with 7 demonstration sites. We now have about 180 pharmacists working in family practices in Ontario. So there's been a lot of growth there, and we subsequently developed and evaluated an online education program for pharmacists who wanted to work in primary care with family physicians, and close to 1,000 pharmacists in Canada have taken that program. So in the early 2010s then, we got some funding to write some case reports on the experience we were seeing in the day hospital. So we published 8 case reports, and if anyone is interested in using those, they actually come with interprofessional worksheets so that people can use them for teaching and case discussions, and I can provide a list of them to you, or they're actually listed on our website as well. And that sort of led me into doing a lot of polypharmacy education with physicians and pharmacists, and these questions were still coming up. How do I decide if I can stop the drug? Can I do it safely? What will happen? Et cetera, et cetera. And that led us to this conversation about the fact that guidelines always tell you when to start a drug, but they don't tell you when to stop a drug. And that was really our light bulb moment. Maybe we should try to develop Deprescribing guidelines. So in thinking about that, we looked at definitions, and as you know, guidelines are meant to really infer what usually will work best for a patient. They're informed by a systematic review of the evidence, in this case, a systematic review of deprescribing, and then an assessment of the benefits and harms of different care options, which could be to continue the medication, to reduce the dose of the medication, or to stop the medication. And it's really taking that information and then integrating it with clinical experience and patient preference, where you can come to a decision about what to do about a medication. So this is a figure from our methodology paper about the guidelines that shows the various steps that we used in developing the guidelines. We started in 2013. We had, again, a provincial grant from 2013 to 2016 to develop the guidelines. And we used we wanted to make them rigorous. We wanted to have them be high quality. We wanted them to be transparent because we wanted them to be trustworthy guidelines that people felt that they could be confident using. So we did use the GRADE approach, where it's really a series of methods that guides your panel selection, your appraisal and synthesis of evidence, and guideline implementation. So we started by establishing the topic, forming guideline development team, defining the scope and purpose of the guideline, generating key questions, and then conducting a systematic review, synthesizing that evidence along with information about the benefits and harms of the different care options, values and preferences, resource implications. We looked at other guidelines that would be relevant, and then we pulled all that together to create recommendations, and subsequently added clinical considerations as well from both the development team and from clinical reviewers and from folks who piloted the guidelines for us. And at the bottom, you see sort of a circular approach where while we were conducting endorsement reviews of the guidelines, we were also piloting the guidelines in 3 long-term care sites and 3 family health teams. And then subsequently, we were able to produce tools that would help to make the guidelines usable in practice. So I've always wanted to use this slide in a presentation because I think that for most people, the previous slide is what's happening in the middle here where the miracle occurs. So we start with all of this information. We go through all of those steps. And in the end, we produced these outputs, which are concise decision aids, these algorithms. First of all, how many people have seen the algorithms? Okay, a lot of people have seen the algorithms, great. Concise decision aid tells you who the guideline applies to, what you should do, how to do it, what to monitor, what to do if symptoms return. So a minute ago, I asked you to put your hand up if you'd seen the algorithms. Now put your hand up if you have actually read one of the guidelines that the algorithm is based on. Oh, excellent. I was going to give out pens because I thought there would only be 3 or 4 people, but I don't have enough pens. So thank you. I'm so happy you've actually read the guidelines, so you actually know what information has gone into their development. So I'm going to switch gears a little bit here and start to talk about some of the challenges. So the first challenge was the fact that we had to make decisions about the scope of the guidelines. So we wanted the guideline to be applicable to those who are at risk of harms, in our case, older people, but we didn't necessarily have evidence that was specific to older people. So in the end, for our deprescribing reviews, systematic reviews, we had to basically say we would look at all adults 18 plus. And this is just because this is where the evidence was for the systematic review. And they were younger and healthier than we would have liked them. Well, that sounds terrible to say we would have liked them to be. But I think you know what, you understand what I mean. We also had to identify exclusion criteria. So we had specialists on each of the guideline development teams that were helpful in identifying exclusion criteria. And then we had to decide for the drug class, was it going to be a guideline for all indications for that drug or just certain indications for the drug? And I'll show you some examples of that here. And I'm going to try using my pointer and see if this works. Oh, no. Okay, I won't try using the pointer. On the right-hand side, you can see there's a list of 4 indications. This is our PPI deprescribing algorithm, and you can see the exclusion criteria for deprescribing on the right. Barrett's esophagus, chronic NSAID users, severe esophagitis, documented history of GI bleed. So these were all recommended as exclusion criteria by the gastroenterologist on the team. On the left, you see people with mild to moderate esophagitis or GERD that had been treated for 4 to 8 weeks. This is the population where we were able to do the systematic review because that's where the deprescribing evidence was. The group in the middle, peptic ulcer disease, treated for 2 to 12 weeks, ICU stress ulcer prophylaxis, following their ICU stay, et cetera. These were indications where there were no deprescribing studies because there were already limited durations that were indicated. So you see these 3 different groups and whether or not you deprescribe or you refer to a specialist following that. For the benzodiazepine algorithm, again, you see that the primary target for this deprescribing guideline is people taking benzodiazepines for primary insomnia, not for people taking it for unmanaged anxiety. And this is really important because a lot of people interpret this to be a deprescribing guideline for all benzodiazepines, but it is in fact limited in scope to people using it for insomnia, so that's important to know. So next, in terms of information, this is where most of the challenges lie. First of all, in looking to develop our guidelines and looking at the benefit of continuing the drug, we did not do systematic reviews on that topic. What we did was we went to published guidelines to inform our guideline about when to continue a medication. The problem is that there's very little information about the benefit of continuing treatment in people who are older and frail. And similarly, what are the risks of continuing treatment in those groups? Very little information about patient values, preferences, and outcomes. And in fact, for our guidelines, we did literature reviews on patient values and preferences. I think that's something we would change for the future, and I think we would try to have more robust public engagement, and the kind of work that Mike presented around working in communities of color, I think is something to be considered for this as we move forward. There's also very little information on the severity and timing of adverse drug withdrawal effects. I would say the benzodiazepine group is where we have the most information, and studies done from Schweitzer and Rickles in the 80s. We have a lot of information around the timing, the severity, the frequency, and the resolution. But we don't have that for other groups of drugs. And we don't really know for certain how reversible harm from these medications is, and when you might see that reversibility. I have a sense clinically, for example, with anticholinergics, because I've seen it so many times, but there's very little published about that. And finally, it's very hard to assess the financial implications because of all of these, all of the information gaps that exist. Now, I wanted to show you one example here with the benzodiazepine algorithm, again, for primary insomnia. And in this particular one, because we had to do the systematic review, again, for 18 and over, but we knew that harm of benzodiazepines was likely greater in the older age group, we ended up having 2 different recommendations based on age, where the recommendation to taper and stop the benzodiazepine is a stronger recommendation for those people over 65 and a weaker recommendation for those less than 18 to 64. So that's just an example of how we used the harm information, which we gathered by doing a review of harm studies to inform the strength of the recommendation. Okay, I think I've covered the financial implications. So what kind of research would make it easier? On the side of trying to understand more about the benefits and harms of continuing in the medications, I think we need changes to prescribing trials to include more older people, more people with frailty and multimorbidity, and also to capture their values and preferences, and then also to capture harm information in that population. In terms of deprescribing trials, I've covered a little bit of this already. More patient involvement to identify important outcomes. Quality of life is one, and I was really happy to see that Wade and Karina got some funding to look at that, because the three of us have had many conversations about that issue over time. And in fact, Karina spent 2 months with me in the fall on a scholarly visit, and she was actually looking after this patient. So she and I are publishing a case report about that to talk as well about the importance of quality of life. We need to look at, I feel like I'm repeating myself, but adverse drug withdrawal events, we need to understand more about that, about function improvement in adverse drug events. Is no change something that we're looking for when we deprescribe? What is the pill burden? How does that affect people? How does that affect adherence? And we need to do these things routinely and consistently, I think internationally, and I think USDeN has a big role here, and we'll talk about this more at the deprescribing meeting in Denmark in September. To do this routinely and consistently so that future meta-analyses are feasible to gather that information together and to capture values and preferences. I think we can consider observational work too. That's a lot of what I've tried to do in the day hospital over time. Monitor the frequency, severity, timing of adverse drug withdrawal events, compare tapering strategies. For nearly all of our guidelines, we're not able to recommend a specific tapering strategy that's better than another one because there's very little published around the comparison. And then to measure the downstream effects, the represcribing of medication, use of other medications, and the reversibility of harm. So overall, I think we need more research as well on the optimal clinical management during the deprescribing process. It's one thing to tell someone to produce a report that says this medication is potentially inappropriate, this is how you deprescribe it, this is how you taper it. But we also need information that's going to help support the patient, manage adverse drug withdrawal events, manage the return of symptoms with a safer medication. And so that information is going to be very valuable. And people need to really know during that process to help them get out of this paralysis, what they need to monitor, how often, and what to do if symptoms recur. Not only the prescriber, but the patients and the families need to know that information as well. And one of the things I've just been working on recently is just a handout to help people through the SSRI deprescribing process, to help patients understand what's the difference between a withdrawal symptom and the return of depression. So we actually get them to write down what were the original symptoms you had when you started this drug. That's what we're looking for return of depression. So that's been a really helpful way to engage, and we've just piloting that with a couple of people right now. I wanted to highlight the antipsychotic deprescribing algorithm here because you see in this one, we put a lot of emphasis. There were 2 indications here for BPSD or for insomnia, and the management strategies for adverse drug withdrawal events are different depending on the original indication. What can you do if insomnia relapses? What can you do if BPSD relapses? And we tried to make this evidence-based, and you'll see, for example, one of the non-drug approaches for BPSD is music therapy, which has evidence in reducing symptoms of BPSD. So back in 2018, we hosted in Ottawa a 3-day symposium on deprescribing guideline implementation, and Mike attended that symposium. That's where we first really got to know each other well. And we had, I think, 130 people from 10 different countries, a really exciting event. We published 5 proceedings papers from that event, and they're all published in Research in Social Administrative Pharmacy, or RSAP, which you should be able to access through your universities. If you cannot, you can email me at deprescribing@bruyère.org, and I can send you a zip file with the 5 articles. And this is a figure from one of the papers. I think, Mike, you're a co-author on this paper with Wade and Emily and Frank. And this summarizes deprescribing research priorities as the group during the symposium identified them at that time. And so that's a great resource paper to take a look at. These are the 5 papers. And we also, as I mentioned earlier, have a methodology paper for deprescribing guidelines. It's in +1. And an instruction manual if anyone wants to develop a deprescribing guideline. This instruction manual also includes budget information, project manager type instructions. There's lots of information, and that's available on our website. I also wanted to talk about the fact that at the very outset in 2013, we had a comprehensive integrated knowledge translation plan. The idea was to use social media and to produce and disseminate user-friendly tools that would make the guidelines easy to use, as well as educational materials. You know, academically, we would publish in open access journals, but we wanted people to be able to have tools they could use at the bedside, and so we've also produced an app. So you'll find a lot of this information on our website, and that includes links to whiteboard videos. Oh, thank you. If I need the pointer. And also links to the app. So we have a pretty good idea of the effectiveness of some of these knowledge translation approaches. The website itself that I think most people have probably seen has had a lot of views. The guideline page itself, over 267,000 views at last count. The whiteboard videos and the different webinars and testimonial videos on our YouTube channel have been viewed over 58,000 times. The app itself has been downloaded now. Oh, now things are moving ahead all by themselves. The Deprescribing app has been downloaded over 8,000 times. And what I really like about the app is it creates a link between the algorithm and the actual guidelines. So you can click on points in the app, and it will actually link up with that section of the guideline. So it provides more information than just using the algorithm by itself. So we know that a lot of different groups are using the guidelines. This is sort of a tip of the iceberg list of groups we know of. That's one of the things I am trying to do over the course of the next several months is pull all this information together. And I'm working with a group in Australia with Ali Langford and Emily Reeve and Sarah Hilmer. We're doing 2 studies, one where we've been interviewing, and Emily's leading this, interviewing guideline developers about integrating clinical recommendations for deprescribing into guidelines. And the second study is that we're actually going to be emailing a survey to all of these people who have asked for permission to use these algorithms to find out what they're doing with them and what the impact has been, because that's a gap that we don't have a good handle on, is what kind of impact have the guidelines actually had. This is an example of how one of those groups is using the guidelines. They have incorporated both the benzodiazepine deprescribing algorithm and the PPI deprescribing algorithm into a pharmaceutical opinion communication tool that a community pharmacist uses to communicate with a family doctor about a deprescribing opportunity for one of those drugs and a plan. And then they work with the family doctor and the patient to implement the plan. And there's some reimbursement through the government of Newfoundland to support that, and Justin Turner is quite involved in that project as well. So that's one example of how the guidelines are used. So one of the RSAP papers that I spoke about from the symposium summarizes a lot of our guideline implementation experience to that date, that people felt that the process development that we used was credible, that we had wide reach and uptake of the different tools, but that the challenges continued to be that people want alternative drugs. If I stop the benzodiazepine, what drug can I give instead? Common question. Non-drug strategies can be costly and difficult, so I'm very excited to see the grant opportunity for the integrated health in benzodiazepine deprescribing. I think that that's going to be really exciting. This is the big problem I still have in practice every day. We almost never know the original purpose of a medication. And it's partly because people have been on the medication for many, many years. Original prescribers are not around anymore. Sometimes they've passed away. We have no information about why the drug was originally prescribed, and the patients and the families don't remember. And that makes it really challenging to then use the guideline, because you can't get past, why is the patient taking the PPI? So we often are guessing. And people, again, want very specific information about tapering strategies. They get sort of paralyzed by, should I decrease the dose for 2 weeks or 4 weeks? And then they don't take the step because they're not sure what to do. And then time and money are needed to support deprescribing activities in practice. So moving forward with implementation, back in 2018, when we had the symposium, the group that talked about implementation and research thought that future research should really use implementation science, a lens, what works for whom and why, and that we should be looking at different healthcare contexts and levels, patients and the public, clinicians, organizations, and more widely, policy and regulation. How could we deliver interventions in different settings? What could increase deprescribing activities? How can we look at roles and responsibilities to really operationalize teamwork? And then, of course, there's the value proposition, and needing to understand the building blocks that will allow us to calculate that value proposition. What is the ongoing cost of continuing the medication and associated side effects? What are the intervention costs? How do we measure the cost of all of the potential adverse effects and adverse drug withdrawal events? How do we measure costs of non-adherence? Can we explore whether deprescribing in one healthcare environment might impact cost and resource use in other interventions? And how can we reduce intervention costs? So, for example, if we always knew the original indication for the medication, it would be much more efficient and less time-consuming to then develop a deprescribing plan. So I think when I think about the challenges going forward now in the next decade, I really think there's a role for documenting clear and specific indications and the planned duration of medication at the outset that will ultimately make deprescribing easier. Incorporating deprescribing recommendations into all clinical guidelines. I don't think we need separate clinical guidelines for deprescribing, but really we should be aiming to incorporate them into all clinical guidelines, and that might require an emphasis on regulators and funders and journal editors, that they will only publish guidelines that include deprescribing recommendations. That's something I think we could put forward. And then I think we'll talk more today about developing the evidence about the outcomes of deprescribing, including that all that information we need to know about adverse drug withdrawal events and optimal tapering strategies. We need to develop more evidence about the benefit and risk of medications in people who are older and frail, determine whether some of these risks are reversible, and then investigate more about whether quality of life, patient satisfaction, decreased care burden should be valued over risk reduction, and then to develop and use approaches to facilitate shared decision-making with patients. And we are in the process right now, Lisa McCarthy and Wade Thompson are leading a guideline application to update our current deprescribing guidelines, which, as you know, were developed between 2013 and 2016. We developed 3 initially, and then 2 more, one of those in collaboration with Emily Reeves. So there are 5 altogether that need to be updated. And so if anyone is interested in either being on a guideline development team, I know we have some previous guideline development team members here in the audience, so you may get contacted soon about that, but you can certainly speak to myself or Lisa today if you have an interest in participating in that process. For myself, one of the things, again, that I am really interested in understanding is really what difference has all of this work made for patients. And I'm working with Sarah Morton from Matter of Focus and OutNav in Scotland to try to understand more about what individual prescribers and patients have learned and gained, what people are doing differently, and ultimately what difference does that make. So that's kind of my project over the next year or so. And just to finish off, I wanted to come back to my patient. We initially decided we would plan a slow taper. There's not a lot of information around what taper is best, but we thought, well, she's been on it 30 or 40 years. Everybody was nervous, we better go slow. So she was on 250 milligrams. We thought, well, we'll just go down by 25 milligrams every few weeks. And then when we get to 100, maybe we'll go down by 10 milligrams because we had that option dose-wise. In terms of adverse drug withdrawal events, various lists we checked, which seemed to be sort of a clinical consensus type list versus based on any studies, suggested we should be looking for anxiety, dizziness, nausea, vomiting, headache. We also knew what side effects of the medication we wanted to monitor for that we hoped would improve her cognition, her dizziness. She had a tremor, and urinary retention. So we actually had PVRs that we could look at to decide if that was improving. What happened was several weeks later, when she was at 150 milligrams a day, she started to get nauseous. So she stopped the doxepin completely. 3 or 4 days later, her daughter phoned and said, she stopped this medication, and I don't know, should we restart it? And she spoke with our doctor, and our doctor emailed me in a bit of a panic and said, what do you think, should we restart? And I said, well, she's still having nausea. Oh no, she feels much better. Well, okay, let's just watch and wait. And we'll tell them if anything untoward happens, if you feel any of these other symptoms, call. 2 weeks later, we get a phone call from the daughter. So she had finished the day hospital by now, but we get this phone call from the daughter. Oh my God, her mood and her cognition have dramatically improved. She is following recipes. She's cooking. She took the garbage out. She is using her phone. She's finishing sentences. She's so much better. So 4 weeks later, we had her come in and do a MOCA, and it had improved from 19 to 25. And I remember having a conversation with her, and it was like a completely normal conversation. She finished every sentence. She was thrilled. She was happier than she'd been in years. And then she took out her phone when she was leaving to call an Uber, which I can't even do. So it was just phenomenal. And like objectively, this was the difference in her cube and her clock before and after. And I know people are going to take pictures. Karina is actually working on a case report for this, so we'll publish that as well and put that on the website. I'm not a geriatrician, so I don't know how significant that is, but it looks significant to me. Mike is nodding, excellent. So I think for me, I'll finish here because this is kind of the reason that I'm doing this job. And anything we can do to make it easier for people to deprescribe, I'm all in. I hope that overall, I'm so excited to be here today to see so many people who are doing deprescribing research and interested in moving this field forward, because I think we can have this kind of impact on many, many, many people. So thank you very much, and I'm open for questions now. Yes?
Okay. Hi, my name's Kaylee Hayes. I'm from Brown University. So I actually did my PhD at the University of Toronto, and on medication kind of use generally. But one thing that I thought was at the forefront of a lot of our research and the results and dissemination and funding, honestly, was the fact that there was kind of a more cohesive payment structure for drugs in Ontario in terms of like having the Ontario drug benefit. And now that I'm in the US, like, it seems like less at the forefront. Like, we're not really thinking about like formularies as much because there's so many different payers. So I'm wondering if you could just kind of discuss whether, you think kind of having the provincial drug plan was a facilitator, something neutral, or something that was incorporated all into your deprescribing work.
Yeah, I think it's definitely valuable on the clinical side. So for people who don't know, patients who are over 65 in Ontario have a co-payment system where the government pays the majority of their medication costs. They pay a deductible and a small co-pay for each prescription dispensed. But for the most part, most drugs are covered. Some drugs are on a limited use kind of formulary where the physician has to write the reason for the drug. But typically, if something is not covered, it's either because it's ineffective, or massively expensive, or very new. So I think having that opportunity to switch drugs or change to different doses is pretty easy for me. And that's why on the backs of each of the algorithms, I didn't show this, but on the back, you'll see there's a little chart that shows the medications available in Canada. And I believe that there's a little star showing whether that's covered by the Ontario Drug Benefit Program. So for example, with proton pump inhibitors, not weirdly, only the higher doses of proton pump inhibitors are covered, not the lower doses. This is, I believe, I hope there's no pharmaceutical reps here, partially because it's the pharmaceutical companies that apply to ODB to have their drug covered. So if they only apply for the higher dose to be covered but not the lower dose to be covered, it's harder to get the person off the drug. Just saying. So there are 2 PPIs, I think, where the lower dose is covered. So we always switch people, for example, from pantoprazole to rabeprazole because the lower dose is covered. That's part of our tapering process. But yes, it's very easy clinically, and we kind of incorporated that into the guidelines. So in different countries, including in the US, where people have wanted to use the algorithms, they've made their own chart to say like what's available in the US, dose-wise, and generic name-wise, because some of it's different. But I could see that you could also, say if you were within a healthcare management system that had certain drugs were covered and certain drugs weren't, you could put that information in the box on the back of the algorithm to help people make decisions.
Thank you.
Anyone else?
First and foremost, let's see if this is on. I do have a big mouth, as you know.
It's
Dr.
on.
Farrell. Okay, perfect. First and foremost, thank you for all of your work and your leadership in this area. It's definitely something we've all used in our practice, and the case was fantastic. I'm intrigued because I think from your case and also from experience is the harm equation, right? And there's some cynicism out there regarding the short-term and long-term harm and benefits. So I'm curious with the single-payer model, I'm often envious as a researcher with the single-payer model, how have you guys started framing that out? Because you've been doing this work for some time. Because theoretically, this case went very well.
Yes.
She stopped the medication, but theoretically, she could have been hospitalized.
Right.
So I'm just curious, like, have you been looking at that in public health data in terms of that signal, and especially with some of these higher risk medications where they could have an adverse drug withdrawal event? Because I'm just curious, because our patients are like, oh, I take a little bit, I'll take more, but if we stop a little bit, we stop a lot. And I'm not sure they grasp that. So I'm curious what you've been doing, or others who might be doing that work.
So personally, I haven't done any research in that, but that's the type of research I think that needs to be done.
Yeah.
Clinically, we provide people, as we're tapering, with a medication chart that outlines what we're doing and what they should be monitoring for and when to report back to us. We have had situations, particularly with tapering furosemide, where the person had no signs whatsoever of cardiac failure, but had swollen ankles from their amlodipine, so we start We stop the amlodipine, then we start tapering the furosemide, and then they end up in emerge and congestive heart failure. We've had that happen a couple of times, so there is risk.
Yeah.
And so I think the close monitoring and informing both the patient and the prescribers and the pharmacist. So this medication chart goes to all of those people, so everyone is in the loop. So we try to do our best to make sure we're going slowly and carefully and monitoring and impress upon people that, while not scaring them at the same time. So it's a kind of a fine balance, but I think more, it would be helpful, and I've tried to propose this at work, that we follow up with some of these patients at 6 months and a year, because it would be interesting to know, does she eventually need an antidepressant again? And we don't, and that's the re-prescribing piece of the equation that we need to know more about. So yes, there's more work to be done in that area.
Thanks, Barb.
Hi, I'm James Shepherd from University of Oxford in the UK. Thanks very much for a really interesting talk and obviously fantastic work you've been doing. I was interested in the challenges of developing guidelines and all the things that we don't necessarily know about. And I wondered is it possible to develop these sorts of guidelines for any medications, or are there situations where you've thought about developing a guideline and then due to the lack of evidence available, you've not been able to do so?
So when we started the whole process, I didn't talk about this, but we did a Delphi consensus across Canada to try to understand what were people's priorities for deprescribing guidelines. So that paper is also published in PLOS ONE, and it's helpful to understand the types of drug classes that people were looking for guidance on. So we started there with picking the first several, where I think guidelines that need to happen are antihypertensives. There's a group out of Switzerland and Sweden leading an antihypertensive deprescribing guideline right now. There's a group in Ottawa leading a statin deprescribing guideline. There is a group in Australia that has just published online an opioid deprescribing guideline using this process. That's open for public consultation. I think we need something more to guide anticholinergic deprescribing, so tricyclic antidepressants, et cetera, and SSRI and SNRI deprescribing. There is some work, I think it's Parag Goyal who's doing some work with cardiovascular medication deprescribing, whether there's enough evidence to lend itself to producing a guideline versus some guidance. I'm not sure, but I think, ultimately, I really think all therapeutic guidelines should have information about if there is evidence for deprescribing, they should include that and the recommendation. If there is no evidence for deprescribing, they should explicitly state that and give clinical guidance around, well, what is the usual duration for the medication? At what point should you reevaluate, and how do you do that? So I'm not totally sure if that completely answered your question, but those are my thoughts.
No, it was really interesting. I mean, obviously, lots of work to do.
Yes. That's why I'm happy so many young people are here.
Hi, Ken Bookfar, New York. Thanks for incredible presentation. As we know, when we change treatments, there's a strong urge to look for effects, and of course, there's the placebo effect and then the nocebo effect. So my question is, should we be trying to advance methods in, N of 1 study, so where we, control for, the knowledge that somebody is either taking or not taking the medicine, and this was, has been an idea that's bounced around and developed up north too, or alternatively, it's just too difficult to implement that kind of study, an N of 1, that is just not worth, trying to advance methods to do that.
It's an interesting question. It took me back to 1986 when I was doing my residency at McMaster in Hamilton, and N-of-1 studies were all the rage then, and I was, I was on rounds with Dave Sackett, and it was an interesting time, and I do think there's value in that, and maybe that's actually why I really like the case report approach to describe what's actually happened to somebody. I don't know a lot about the methodology now for an N-of-1 study, but for me, I do N-of-1 studies every day at work. And then it's telling people about it and publishing about it that I think is important. But maybe looking at a way where we do that using a consistent approach so that we can do some kind of and I don't know if it's possible to do a meta-analysis of N-of-1 studies, but presumably if everybody's using the same monitoring approach, the same documentation approach, you could do that.
Hi, I'm Nancy Schomburg from Johns Hopkins. Thank you so much for a great talk. I'm curious on your thoughts in thinking about deprescribing symptomatic medicines versus preventive medicines, as you mentioned about the statin and the antihypertensives. Sometimes it could be easier because they don't have as much symptom that could come up, but sometimes it's harder to explain to patients as they monitor for these intermediate markers like lipid panels, how to really think about that. So I'm curious on your thoughts on how to think about deprescribing those two types of medicines that are similarities, or what are some unique challenges to each class as we move forward in research that we should think differently about the preventive medicines.
Yeah. That's not an easy question to answer. It's really, really challenging I find, to explain the value of preventive medications to patients. So we had one fellow about a year ago who was having a lot of leg cramps in his legs. He was in his 80s and he had multiple health problems, but these leg cramps were making it really difficult for him to walk. And I remember saying to him, what is the most important thing to you? And he said, I really, really want to be able to walk across the field to go and sit down and watch my grandson play soccer. And I said, it's possible. I don't know, because we couldn't find any reason for cramps in his legs. I said, it's possible it could be this statin medication you're taking, and the goal is to try to prevent a heart attack or a stroke. And I remember the numbers needed to treat. It's something like 80. And so we'll just use that as an example. But I said, about 1 out of 80 people might have a benefit from this medication. What do you think? But at the same time, it's possible, but I don't know the incidence, it's possible it might be contributing to these leg cramps. And we used what we call pause and monitor for 2 weeks, where we stopped it, and his leg cramps completely went away. And so it was very helpful to be able to explain that to him, but at the same time, when you're explaining numbers needed to treat to people, they seem so high that, in this case, he said, that doesn't make sense to me. Why would it stay on this if only 1 out of 80 people benefit? And yet another person might say, well, no, that's important to me. I buy lottery tickets every day, So it's about having the discussion, but I think we need better ways to have those discussions, because not everybody understands these concepts of risk and potential benefit. Is that helpful? Okay. So it was very hard to hear the last part of the question with all the noise in the background. So, yes?
Good morning. My name is Paresh Paul, and I'm a fellow in Montefiore Medical Center in New York. I just wanted to share my 2 cents with you. Is there a possibility of using real-world data that is sitting in electronic health records such as EPIC, or outpatient health records such as MedGen and SigmaK, and use de-identified data, which is HIPAA compliant, to do studies with regards to deprescribing and what are the adverse drug events and what are the other issues that have happened because of deprescribing, and in instances where deprescribing was not done?
Yeah, I'm going to provisionally say yes, although that's not my area of expertise. I imagine that question is going to come up more today. Lisa, I don't know if that's something you are able to comment on?
I think there's other people around me right now that could comment on it more. I think the idea is amazing. The devil is in the details of that one. So I think there's lots of better minds on that are sitting around me that could answer that, but we'll talk more about it today, I think.
Okay.
Hi, Andrew Zullo, Brown University. Fantastic talk. You said one thing earlier that really stuck with me about the need for evidence comparing different tapering strategies. And I know there's more attention among the trialists now, and they're starting to think about doing more trials to answer those types of questions. I wonder if maybe you could comment on what some of the general categories of strategies that the trialists might compare to each other are, and maybe specifically also commenting on whether some of those should be dynamic strategies, where if you observe something for the person, you then modify the strategy accordingly. Thank you.
Yeah. Well, I think the key is in how you finished in terms of the dynamic strategy. So we typically propose a few options to a patient, and we typically allow them to choose what they feel most comfortable with. And also, when we do our monitoring weekly, if they want to pause at a certain dose, we pause at that dose. So nothing is ever written in stone. And so while I say that we need more information on tapering strategies, I actually think we probably have enough on like PPIs, benzodiazepines, we know go slow. I don't have as great a comfort level with how quickly to taper antidepressants. That one I feel that more work could be done comparing strategies. But again, it would be helpful in those trials to monitor dynamically how often that gets modified. And I know that the benzodiazepine withdrawal studies published in the 70s and 80s, I know that they did that as well in those studies.
Hi, my name is Anne Spinewin. I'm a pharmacist from Belgium, and thank you for this very inspiring talk. I have a question on the fact that you mentioned, and I fully agree with that we should try to embed deprescribing recommendations in prescribing guidelines and normal guidelines. I was wondering whether you have any experience in trying to have Canadian stakeholders and guideline developers pushing this forward, because I'm sure there will be many challenges.
So we did do a little bit of work with the Canadian Hypertension Society, because we actually developed a proposal for an antihypertensive deprescribing guideline that we submitted for funding about 3 years ago. And the Canadian Hypertension Society was actually a partner on that proposal. So they were very open to where, I think they sort of saw that this was the future. People had these questions. They needed to be able to respond to them. Unfortunately, that did not get funded. But there's a group, I ended up giving the protocol to Karina and Sven Streit in Switzerland, and they got funding for this international antihypertensive deprescribing guideline. And so the Canadian Hypertension Society is now sort of a collaborator with them on the guideline. So I think there is interest from some of these groups. I don't know, Lisa, did you have any success with the Canadian Diabetes Association?
Yeah, I was going to say Diabetes Canada is kind of peripherally involved in some of our efforts to update the anti-hyperglycemic guidelines. So slowly making traction. It's always, they say, great, we're in, where's the money? So that's always it comes back to that.
And actually, I have to tell a funny story about Diabetes Canada, because when we developed our anti-hyperglycemic guideline, we sent it to them for review and potential endorsement, and they wrote back and said, this is really great. Unfortunately, we can't endorse it. And then like 3 weeks later, they asked me to come and speak at their national conference about it. So...
Hi, Barb. Bob Waller from Team Alice, University at Buffalo. Thank you again for your presentation. One of the things I was interested in, as you're developing the guidelines further, the concept of health span and lifespan and prognosis, because that certainly will then impact where do you want to go with the recommendations.
Absolutely. I'm going to have to go back and fix the slides now, because I forgot to put that on there, but that's a conversation every day in the day hospital. But again, it's about this: what is the risk benefit of continuing all throughout the progression of frailty and to end of life. I know there's a fellow at the Ottawa Hospital. I did point him towards USDeN at one point. He was looking at anticoagulation at the end of life, and the variation that is seen in different hospitals around people who are still taking anticoagulation, even in the last few days of life on a palliative care unit. So that, I think there's a lot more work to be done in that area as well. How do you make these decisions, and how do you have these conversations with people? It's difficult. It's a great comment.